Questions for the panel? Comments? Yes, ma'am.
Thank you. So I have a few comments. One is, I think, as Charu reminded us rightly, but I just wanted to underscore it, enrollment doesn't equal service utilization in the case of informal workers. So, countries like to say that they have covered X million workers, but I think the question we need to ask, and there is something to be said for that, giving everybody smart cards, it's no mean feat. So let's accept that, but also let's understand that it does not translate necessarily into service utilization on the ground. And why this is important is because we've been hearing from yesterday that countries have resources. Even rich countries like the US have those kind of discussions. So what is the best use of our resources to reach informal workers? I think we have to ask ourselves in our own countries particularly hard questions. And the other thing that two other points that came out from Charu's presentation in particular is that as these schemes get more sensitive to the ground realities and want to extend to informal workers don't know. So while it's true that above poverty line informal workers, on paper are covered by the policymaker sitting in New Delhi who had that foresight, we don't see it on the ground. We go and say we're not below poverty line, but we are told that we're covered and we're not. So these, the disconnect, and that's where organizations, and I think that's also where a role is there for employers and employers associations. Even if informal workers don't have an identifiable employer, there are strong employers associations and industry associations, certainly in our country, and once they are aware of the reality and once we engage with them, perhaps they'll help us move in the direction that we'd like to. For example, employers associations as a group may be able to put some funding into education for the schemes, since they are in a way benefiting from having healthy workers because the government is paying for all of this. Perhaps they would be interested in funding education and linkages. The third thing I wanted to bring up is the whole question of equity, which on the first day in my presentation, I think in many countries and certainly ours lies at the heart of many issues. We say there are no resources, but then the resources that are there are in such a skewed proportion and leave out the majority. And I think a lot of countries and peoples in our countries are asking, is that fair? And obviously it's not. And just to give you an example, when we were developing the universal health architecture for India, we found that the atomic energy scientists, the nuclear scientists in our country and their families for life have a per capita coverage of rupees 17,000, which I was working at, is roughly about $200 per capita per annum. And here for universal healthcare, we're still talking about $30 per capita per annum. So 7 times the expenditure currently is going on. And I mean, I don't begrudge the nuclear scientists and their families of our country, but how can you have these kind of distortions? Or for example, well, the ESIS that you mentioned, Charu, I mean, it's dealing with less than 6% of the population, and I'll tell you why they won't allow informal workers, because it's based on employer contributions. And the employers in our country still don't understand why they should be contributing, why their contributions should be going for the general informal workforce or the general public. And so we have this strange specter of these white elephants, these ESIS hospitals supposedly serving the formal sector with doctors and nurses and no takers, because they're less and less formal workers. And yet they won't open their doors to us. And this is something that we try to engage with them during our, it's a huge, massive waste of resources of any country, of human resources, of facilities. And even more so for the military and the railway. We found that the military, as you can expect in India, the defense services have the most quality services, the best healthcare in the country. They've developed standard treatment protocols that all of us need to adopt. And when we talk to the military doctors, they say, in peacetime, thank God for peace, But in peacetime, many of them are twiddling their thumbs. They don't have much work, and yet they live in communities that are so poor and full of informal workers. So at the one-to-one level, the military doctors are ready to engage, but that requires a major change in the Ministry of Defense so that in peacetime they can serve the communities in which they live. So these are the kinds of questions that I guess what I'm trying to say, it's not the lack of resources again, it's how we use the resources, who gets covered, who gets left out. And these are hard things. We decided as a group when we were making the universal health architecture that these were not just one elephant in the room, a herd of elephants in the room. And we wouldn't be able to move forward if we started tackling all these hard issues. So these hot potatoes have been left for the moment. But I think, perhaps this is my last point, is perhaps this is something like that a forum like this could begin to engage with policymakers and others in our country to ask these difficult questions and find ways out, because surely there are ways out.
Thank you, John. I couldn't help but, sharing some of the ideas. Listening to Dr. Yuka's intervention about the fact that this should be more about non-health intervention rather than health, that we seem to be concentrating on the health aspect. The thing I like to share is that one of the things that I believe would be the crucial entry point is to make sure that the district health system or the primary care that Ivan alluded to has new roles and new ways of working. And to me, this will be one of the very important challenge, not only for the health of the informal workers. And we kept talking about social determinants of health. So I hope that, if we are thinking about how we could improve health of the informal workers, whether under UC or not, one of the important partners would be health systems at the district level or the primary care level. When Paravi made her concluding remark this morning, she mentioned about multi-partners. To me, the more important thing would be the connector. Who will be the connector of these different partners? And I believe that, occupational health or informal or formal, when their health deteriorated, it's a burden on the health service providers. It would be better for us to reorient the health service workers to know that they should be more proactive and preventive. And to me, reaching out to make sure that the various health risks is being managed would be very crucial. So it would be important. Without, we could discuss a lot who could be the so-called good entry point for the informal health workers' health. In the formal workers, you have the employers who are more directly responsible. But for the informal, no matter how hard you can try to talk about the polluter pay principles, you can only talk about money, but you cannot talk about responsible units or actors. So I would like just to highlight that point, to make the linkage that even though it may seem to be the ILO business, but maybe one of the very important actors would be the health sector, especially at the primary care level. Thank you.
Just thank you all for all the rich data that was presented, frankly, because Charu in particular, just seeing how this plays out both on coverage, however defined, and also on financing. But one of the things that, since yesterday that we've been thinking through is recognizing that the private sector, not only is it diverse, whether you're in civil society or in a formal company, but also the roles that a private company plays differs. They're not just employers, right? There's so much more that's happening. And I think a lot of the issues that have been raised, especially in this panel, and especially in India, frankly, because of the CSR 2% law that's in place, allows us to think creatively about how the private sector can engage on these topics while working through the thorny national employer issues of whether they feel directly responsible or not. There is an opportunity to be able to take the resources that they're now required to contribute and channel it back into some of these interventions in areas because they will likely say we are contributing because now they have to because of the CSR law. And so that may only add more of the complexity that Nurai is raising about employers not feeling that it's their responsibility, and now they may be feeling, well, we've taken care of it because of the CSR law. So just trying to think creatively about how we use the private sector.
he's gone, but I like to respond to the point intervention by Samsak. One of the big lessons learned for the ILO is the choice of the partner or the counterpart on each programs. So the important thing is who is the best person, best organization or institute or the mechanism to reach out to that specific area of informal economy workers. For example, in terms of the farmers, small-scale farmers in Thailand, we chose the counterpart is the Ministry of Agriculture. But in terms of the same small-scale farmers in Vietnam, we chose the Women's Association and Farmers Association at the community level. In terms of the small-scale construction workers in Mongolia, we chose the employers organization because they have very good outreach to those workers. So that's our lesson learned.
I just wanted to comment on Laura's presentation, which says the bottom-up also works. So while some of us are working in terms of the top-down at macro policy, international processes and government levels, so the bottom-up is very important because those gives you the tools and solutions that can begin to start working. And the key area about the private sector is made up of multiple players. And one of the key areas is universities. I mean, you still have large numbers of activist students. And to run a health camp, final year medical students can run a very good health camp, provided it's done in a sustainable manner and things. Because the problems that we have is often we don't want to be like MSF, you know, parachute in. They're doing a good job, MSF, don't get me wrong. But you parachute in, you deal with an emergency, but there'll be 100 other emergencies that come up. So part of the process is how do you build sustainable delivery mechanisms? So you start off with the mechanisms of working with young medical students, young nursing students, occupational hygiene. And I think the university partnerships begin to deliver some of that agenda. When we talked about the evidence-based earlier on, some of the bright MPHs, can we get some Master of Public Health students out there to help us with the data mapping and the, you know, this thing. And you don't need to cover the whole country. Just start with Warwick Triangle, start with some farmers organizations in Vietnam, and you start building the evidence base. And that's the kind of stuff that we are asking for, is to start actually stimulating these new areas of engagement, as opposed to the traditional stuff of, you know, the Rockefellers. I mean, we need that leverage money, so don't get me wrong. Because the convening power of a workshop like this took some funding. So that's why we sit around this table. So likewise, you can have those similar funding opportunities that brings together the small farmers organizations, the women's groups in a local village. But somebody has to pull that together. And often the big issue is, most of us around this table, of course, we are funded to be at this table. I don't lose a day's salary by coming to this meeting. For that village worker who comes to a meeting, they're losing a day's salary. So often we must actually work through what do we do in terms of, you know, paying that extra subsidies or whatever it means. So let's think through those issues. But what I was just going to say, that Laura's presentation is very important about a bottom-up grassroots movement that begins to start pulling some of these solutions that we could work with as we move up the ladder. Thanks.
Thank you for your comments. And I think it's absolutely important to have policymakers being engaged in all this. And one of the things that I just want to place here is that we really do not have much evidence in India on informal sector workers. And that's the first thing, and that's where the university staff and other people come in, that we need to first produce that evidence. It was this evidence on out-of-pocket expenditures. I know I've done work on that, Peter has done work on that, and several others of us have, that actually made government to think about BPL, RSBY kind of schemes. So it is something that we need to bring to the table and make policymakers aware about that. That's the first thing. It's of course education for the informal workers, but it's also the education for the policymakers. That's my first primary thing that I think I would like to say. The second thing that I think I just want to put out here is we are moving towards a path. And that's what is important. I do agree, and I've been saying that it's only tertiary care, it's only hospitalization, but still 1/7 of the people enrolled actually took hospitalization care, and out-of-pocket expenditures have fallen down. So there is a positive movement. We should keep to it, and we should see how we can increase, how we can move towards that cube, the small cube in the bigger cube becoming bigger. So that is what I think we have to think about. And that's where I think I come from in terms of moving towards universal health coverage with informal sector workers.
Well,
thank you very much for extending the time for my question. I would like to address my question to Dr. Ivanov. And actually, not just a question, but also an expectation when we mapping out the resources for occupational health or public health in common. I think we have to go beyond the conventional health workers. We have a big issues within the Ministry of Health. Oh, I'm sorry. My name is Hanifa Deni from Indonesia. And thank you very much for inviting me. And I gain a lot of new knowledge and experience by joining this meeting. I would like to address the issue that the Ministry of Health only recognize the health workers in consequent with the additional salary. They only recognize doctor, nurse, and then sanitarians, and then clinical nutrition. While in the real fields, actually not just those workers that health workers that have been stated in the government system. So now we are trying to move forward beyond that kind of traditional identification of health workers, because every profession and health world, actually they contribute a lot. That's why when Ivan presented about there is a lack of education on occupational health in the undergraduate, that is not true. Because when we talk about Indonesia and Thailand, I know a lot about Thailand because I visited Thailand very often, and I'm a good friend of Somkian. I think we have a big, and also the Philippines, the public health education have seven departments. That one of the department is occupational health and safety. I'm the president of the Indonesian Public Health Union, and we have 187 colleges of public health in Indonesia. So if all the public health join my organization, that could be 700,000 public health professionals that they work in the 7 departments, including occupational health and safety. Unfortunately, 90% of them really only interested in working with the oil and gas companies. That is the problem, the grassroots problem, not the lacking of curricula. Because when they work for the oil and gas company, they can earn maybe 50 times or 30 times than the salary of their professor. That's I think this is also very emerging issue that we have to go beyond our conventional on what we have done now. Thank you so much.
thank you. Dr. Howard,
Well, we're finished with part one. We'll take up part two after lunch.
thank you. This oil and gas doctor will see you all at 2 o'clock. Thank you.